Welcome to the deep dive. Today we're getting into a pretty important document from the New York State Office of Mental Health. It's the 2023 MHOTRS Programmatic Guidance.pdf.
Right, MHOTRS. That's Mental Health Outpatient Treatment and Rehabilitative Services.
Exactly. And this guidance under Part 599 of the state regulations is basically the rule book, the blueprint for how outpatient mental health care works in New York.
Yeah, it really is.
So our mission today is to pull out the key stuff, the most important bits from this guide to give you a clearer picture of this whole framework.
We'll be looking at, which programs it applies to, the actual services they have to offer or can offer.
And even how they're supposed to deliver them, document everything, all that operational stuff.
Exactly. The source itself, it covers a lot. Starts with an intro to the rules, the why behind the guidance, then gets really specific required services, optional ones, some needing special OMH approval.
OMH being the Office of Mental Health.
Correct. And things like delivering services off-site, the rules about being in, say, 2 different programs at once.
Ah, the co-enrollment piece.
Yep. And specific program types like ACT Assertive Community Treatment or PROS, Personalized Recovery-Oriented Services. Plus, it defines key terms, assessment, crisis intervention, medication treatment.
So it's pretty detailed.
Oh, yeah. Down to staffing, policies, paperwork, even how they review if services are being used appropriately. It's quite thorough.
Okay, so for you listening, if you're curious about how mental health outpatient services are structured in New York, maybe you work in the field, maybe you're trying to understand the system for yourself or someone else, this deep dive should give you some really valuable insights. We want to highlight the scope and the real nature of the services.
Definitely.
All right, let's dive in. What really jumped out at me first was the purpose, the stated goal. It feels like it's aiming higher than just, managing symptoms.
It really does. The guidance states pretty clearly the aim is to set up programs that tackle the symptoms and the negative effects of mental illness as early as possible.
Early intervention is key then.
Absolutely. And what's interesting is the heavy emphasis on person and family-centered recovery. That language is important.
What does that signal to you?
Well, it suggests a shift, right? Away from just focusing on the illness itself toward prioritizing what the individual actually wants, their goals, and helping them integrate back into the community as much as possible.
So maximizing potential, using evidence-based stuff.
Both precisely. Using practices that are shown to work, it feels proactive, holistic. That whole philosophy seems to run through the entire document.
Okay, so who exactly has to follow these rules? You said it was broad.
It is very broad.
Yeah.
It applies to what they call Article 31 MHOTRS programs, basically. Those licensed or run by OMH, the Office of Mental Health.
Got it.
But it doesn't stop there. It also includes programs OMH licenses jointly with OASS, that's the Office of Addiction Supports and Services.
Right, handling addiction issues often alongside mental health.
Exactly. Or jointly with the DOH, the Department of Health. And interestingly, it even pulls in hospital outpatient departments and certain non-hospital clinics, these DNTCs.
Diagnostic and treatment centers.
Yes, if they hit certain thresholds for how many mental health visits they handle, like over 10,000 a year, or if mental health is more than 30% of their visits. There are a few criteria.
Wow. Okay, so it's not just the dedicated mental health clinics.
No, it casts a pretty wide net. It really shows they want these standards applied consistently across a big chunk of the system.
That makes sense. So let's talk services. You mentioned required versus optional. What falls into that required bucket? What's the baseline?
Yeah, Section 599.8 lays this out. The required list is pretty comprehensive. You've got assessment and screening, basically figuring out what someone needs.
Consider intake stuff.
Right. Then psychiatric assessment for diagnosis and planning, crisis intervention for immediate help.
We should probably circle back to define that one more later.
Good idea. Also required, psychotropic medication treatment. And they specifically mention injectable forms, too, for adults and kids. Then psychotherapy, various kinds, and complex care management.
Complex care management. Sounds important for folks with multiple needs.
Very. So that's the required foundation. The idea, I think, is to ensure a certain standard of care everywhere.
Okay, and the optional services, how do they fit in? Is it just like bonus stuff?
Kind of, but they're split. First, you have optional services without OMH approval. These are things programs can add on their own.
Like what?
Things like peer support, which is huge, health monitoring, they even call out smoking cessation, and health physicals. It shows they recognize that mind-body connection.
That's good to see, encouraging a broader view of health.
Definitely. Then there are optional services with OMH approval. These usually need more specific resources or expertise.
So more specialized things.
Exactly. Think various kinds of testing, developmental, psychological, neurobehavioral testing, and also intensive outpatient programs, IOPs.
Okay, so there's a base level everyone gets, then programs can add things, and for some specialized stuff, they need OMHs okay.
That sums it up well. It balances the standard core with flexibility and oversight for the more intensive services.
Makes sense. Now, you mentioned co-enrollment earlier. Can someone actually be in, say, two different MHOTRS programs at the same time?
Yeah, that's handled carefully. The guidance basically says co-enrollment in two MHOTRS programs isn't the norm. It's more the exception.
Why is that? Risk of duplicating services.
That seems to be the concern. If it is allowed, it often requires completely separate treatment plans for each program, to make sure the care is distinct and focused, not just overlapping.
But there are cases where it is allowed.
Yes, some specific combinations. For example, ACT assertive community treatment, which is very intensive. Remember, it can sometimes be combined with other services, but the guidance calls it a limited allowance.
Meaning, proceed with caution.
Probably requires strong justification. On the flip side, something like partial hospitalization, which is already pretty intensive, day-long treatment that's generally listed as not allowable for co-enrollment with another MHOTRS program.
Okay, so they're really thinking about how these different intensities of service fit together, or don't.
Right. It seems aimed at coordinating care and avoiding confusion or duplicated effort.
Let's go back to those definitions. You flagged crisis intervention as important. What exactly does the guidance mean by that?
It's crucial, yeah. They define it as services specifically designed to help someone who's in acute distress or maybe at risk of a crisis.
So immediate, urgent situations.
Exactly. The goal is to de-escalate things safely and respectfully, and importantly, to try and prevent needing more restrictive interventions.
Like ending up in the ER or admitted to a hospital inpatient unit.
Precisely. It emphasizes immediate support, but in the least intrusive way possible for that critical moment. Think maybe mobile crisis teams, phone support, that kind of thing.
Gotcha. That clarity is helpful.
Yeah.
What about the other one we flagged? Complex care management, or CCM?
CCM is defined as time-limited help focused on addressing not just mental health symptoms, but also related functional issues someone might have, maybe tied to medical problems or other needs.
So, looking at the bigger picture of someone's life.
Yes. And a key part, they state, is care coordination. That means actively talking and working with all the other people involved in someone's care. Doctors, therapists, maybe vocational counselors.
Connecting the dots.
Totally. It underlines that integrated approach, recognizing mental health doesn't exist in a vacuum. It could involve helping someone manage appointments, coordinate between different specialists, or build daily living skills.
Okay, shifting gears a bit. How do these programs actually run? Staffing seems like a huge piece. What are the rules there?
Absolutely critical. The guidance mandates that programs have enough professional staff, and they define that term.
How so?
It means practitioners who have a specific license or limited permit from the New York State Education Department related to mental health treatment.
So qualified, credentialed people.
Yes, it underscores that need. They even define roles like psychiatrist and medical director, spelling out the qualifications and duties expected for those key positions.
Ensures a certain level of expertise is available.
That's the idea, making sure people get care from appropriately trained professionals.
And beyond just who works there, what about the rules of operation, like protecting privacy, handling complaints?
Very important points in the guidance. Programs must have written policies on confidentiality. Makes sense, given how sensitive mental health info is.
Absolutely.
And they also have to have a clear, defined grievance process. So if someone receiving services has a problem or a concern, there's a formal way for them to raise it and get it addressed.
So protecting client rights and ensuring ethical practice.
Exactly. Those procedural safeguards are built in.
What about documenting the care itself? You mentioned treatment plans earlier.
Right, the initial treatment plan is a big one. It has to be done within 30 calendar days of admission.
That seems like a reasonable time frame.
And it has to include specific things. The person's needs, their goals for treatment, who exactly is providing the services, like which type of staff and how often and for how long they expect each service to be needed.
So a detailed roadmap created early on.
Yeah, that emphasis on timely, detailed planning points to a very structured approach to treatment. It's not just winging it.
Okay, one last operational piece. Utilization review. What's that all about?
Utilization review, or UR, it's basically a quality control check. Programs need a written policy for it
To review what?
to review if services are being used appropriately. That includes looking back at whether admitting someone in the first place was the right call, and then checking periodically if they still need the services they're getting.
So making sure resources are used effectively and people aren't getting like too much or too little service.
Exactly. It's about responsible resource allocation and ensuring the care is actually necessary and beneficial. Promotes quality and efficiency.
Okay, wow. We've covered a lot of ground. If you had to boil it down, what are the main takeaways for someone listening about this MHOTRS guidance?
Well, I think the big picture is that New York State has a really comprehensive and structured system for outpatient mental health. There's a clear push towards person-centered, recovery-focused care.
Right, that holistic view.
Yeah. And you have this mix of required and optional services, allowing for both consistency and some flexibility. The rules around co-enrollment show they've thought carefully about coordinating different levels of care.
And the focus on qualified staff and good documentation.
Absolutely. And those definitions, like for crisis intervention and complex care management, they really highlight the multifaceted support these programs are meant to offer.
You know, thinking about it all, the level of detail is pretty striking. Even defining optional services, the nitty-gritty rules on co-enrollment, it feels like a serious effort to create a really well-defined, coordinated system.
It really does. That granularity suggests a strong commitment to setting clear standards and trying to make sure care is integrated properly.
So for anyone interacting with this system in New York, whether seeking services or providing them, what's the bottom line? What does this guidance mean practically?
Understanding this framework gives you really valuable context. You get a sense of the expected standards of care, the kinds of support that should be available.
And the rules that are supposed to ensure quality and appropriateness.
Exactly. For someone seeking care, it helps you know what to expect, maybe what questions to ask. For professionals, well, it's the playbook for operating correctly and effectively.
This has been super helpful, getting this inside look at the regs. It definitely makes you wonder, though.
What's that?
Well, with guidelines this detailed, how does it all translate on the ground? You know, into the day-to-day experience for people actually getting the treatment? What are the real-world challenges and successes in putting such a complex framework into practice?
That's the million-dollar question, isn't it? How policy meets reality.
Something for all of us to think about as we consider the whole landscape of mental health care. Thanks for digging into this with me.
My pleasure. Always interesting.